Hello, I'm Dr. Annalene Weston, dentolegal consultant at Dental Protection. Welcome to RiskMatters, our latest series of podcasts created specifically for dental practitioners in Australia. As the name suggests, RiskMatters is all about managing risk. In this podcast series, we'll be taking your feedback and queries and putting them to leading industry experts, getting them to answer the difficult questions about managing risk and working safely. It's about what to do when managing risk matters most. So in this edition, we're going to be chatting to Adjunct Associate Professor Geraldine Moses about the recently updated therapeutic guidance. So let me begin by introducing her and we'll take it from there. So Dr. Geraldine Moses is a doctor of clinical pharmacy who's worked with the dental profession since the 90s. She was the provider of the ADA's National Pharma Advice Service from 2013 to mid-2024. And she's now providing a new advisory service with a group of dental experts called the Dental Advice Network. She also consults privately at a multidisciplinary dental practice in Brisbane and continues to work part-time as a medicines information pharmacist at the Mater Hospital in South Brisbane. Geraldine holds the position of Adjunct Associate Professor in the Schools of Pharmacy at UQ, QUT and the Dental School at UWA. She's published over 30 peer-reviewed journal articles and with dental academic colleagues recently published a textbook through Cambridge University Press entitled The Handbook of Dental Therapeutics. She's also a member of the expert writing group for the Therapeutic Guidelines, Oral and Dental. And in 2019, Geraldine was made a member of the Order of Australia for her service to healthcare as a pharmacist, as she absolutely should have been. So, thank you so much. Now, to be clear, for those of you who aren't sure what we're talking about when we talk about the Oral and Dental Therapeutic Guidelines, we're talking about the Clown Book. Okay? Now, the Clown Book in my hand is version 3. We are recording now in October 2025, and there has been a new version 4, hasn't there, Geraldine?
Yep.
And that was released?
Well, early September, so just a couple of weeks ago.
So a few short weeks ago, but some of our colleagues are not aware of that. The reason being that they haven't received a new Clown Book.
Yes.
Now, I've spoken to the ADA about this in preparation for this conversation with Geraldine because I thought it would be most unhelpful if we didn't tell you how to access this guidance, which is really important, and the guidance that we're expected to work by. They have advised me that we will be getting a complimentary, so at no charge to us, copy of the therapeutic guidance, version 4. But at this stage, I don't know if it's going to be a new Clown Book or if it's going to be online, but it is coming and they're going to keep us up to date about that. In the meantime, you can actually access this and all the therapeutic guidance for all the other parts of the body by going on the Therapeutic Guidelines webpage. There is, however, a fee associated with that, but it is, of course, helpful to see what all the other professions need to know, I think.
Yes.
And certainly it's something that we at Dental Protection, we have you can buy practice membership's not the right word, log-ons, and we have a practice log-on for dental protection so we can see all that guidance. It might just be something people want to consider. Okay, so it's coming. It's available already if you want it. I really wanted to touch in with you, Geraldine, because I know that each therapeutic guidance brings with it big changes. What are the big changes that we as clinicians need to know about for version 4, please? In a nutshell.
In a nutshell, Annalene, there are huge amounts of changes. So the clear message to listeners has to be that don't just assume that because you've read version 3 that version 4 will be largely the same. There are gigantic changes in almost every section. And indeed, there'll be a lot more information available. So if they do get around to actually publishing a hard copy, because dentists are the last ones to get a hard copy of a therapeutic guideline, all of the other editions like antibiotic, analgesic, wound care, endocrinology, neurology, do not come in a hard copy anymore because they're just too big and too hard to make small enough to be a book, a carryable book. So that if there is a hard copy, it'll be at least twice the size.
Wow.
And that just then shows you how much more information there will be.
Sure, absolutely. So Big changes. Where do you want to start?
I'd like to start at the very beginning, and I guess I'll highlight that there are huge changes in analgesia, antibiotics, and those are the nuts and bolts of dentistry, aren't they? Not many in local anaesthetics, but an important one we probably should just quickly allude to. A huge section on managing patients with medical conditions that's been updated and increased. And they used to be the sorts of questions I get frequently on the pharma advice service. So I do think there's a need for that. A lot more information on corticosteroids and the role of drugs like dexamethasone, especially for managing post-op pain and swelling, and kind of still saying they'd rather people didn't use that, and much, much more. So let's start at the beginning, if that's okay.
Yeah, let's do that. I'm loving this.
So the very first chapter, and I think it would be great if our listeners, when they do get their access, whether it's hard copy or electronic, to the new guidelines, sit down and actually read it. Read the first few chapters in particular, because there's so much lovely guidance on where to go for practice guidelines and the act of using drugs. That we know that the emphasis in therapeutic guidelines is about the role of medicines in whatever you do with patients, because there's so many other medical areas where they write guidance. So the ones that I drew attention to, and these are the ones I contributed to in the writing of them, both the third edition and this one, is the one on using medicines wisely, and things like quality use of medicines, and then what is prescribing, because people think that if you know pharmacology, you know how to prescribe, and like pharmacology is chemical structures and receptor sites, like who cares? Prescribing is like an iterative process. It's an intellectual process of thinking about where medicines fit in treating people. But even you could prescribe exercise, you could prescribe rest, you could prescribe a dental procedure. So prescribing is recommending a treatment, but when and where that's most appropriate is totally different from knowing pharmacology. And yet most dentists are not taught about prescribing. And another big area that we try and cover in the book is the legislation behind dentists' role in prescribing, and also where that fits in with supplying medicines. So we've got some really like no-brainer stuff about what is a prescription and what does it look like and what needs to be on it. But the other more intellectual stuff about the competencies involved, and you guys at Dental Protection have you had something to do with these new prescribing competencies at all, Annalene?
No, we're just aware of them. We didn't feed into them.
So dentists need to be aware that all of the professions who have prescribing rights are very soon going to be subjected to assessment of their ability to be competent as a prescriber, and it will be part of your registration. It's not happening right now, but it will eventually. So we do talk about what those prescribing competencies are, and we refer people to the curricula to assess and teach competency. And then we also talk about the top 10 prescribing skills in managing the prescribing process. Because it really is a process. It's a cycle too, isn't it? Because it always should end with review. But then we get down to the nuts and bolts of individual types of prescriptions. Because as we know, most dentists just have the normal PBS prescription, but that's not the only type of prescription you could write. And then when do you not use a prescription? So many dentists have access to some medicines in their practice that they often provide directly to patients for them to take home. And often they sort of sit there going, do I write a script for this? So we make it clear that the prescription is not for you. It's not for your records. It's as a communication tool between you as the diagnostician and the health professional managing the dental care, and sending that message through the prescription to a dispenser. Now, that dispenser is usually a pharmacist, but not always. Sometimes it's a nurse, or it could be a technician. And it's to say, this is like what I want you to prescribe for the patient, dispense for the patient to take home. And that's the key bit there, is about for taking home. So if we move on to dentists who actually give the medication, like they might have a little dispensary in the dental practice that has Panadeine Forte and amoxicillin and Valium and a whole bunch of other drugs that they can give directly to patients. They need to know that this outlines then the responsibilities you have of looking after that little dispensary. And if you're going to provide medication to a patient, that you are expected by law and by professional standards to dispense that to the same standard as a pharmacist, because as you probably know, pharmacists are subject to legislative standards for dispensing. Now, they often don't outright state that in the legislation for dentists, but that is what is expected.
Mhm.
So they, in therapeutic guidelines, have this lovely checklist of what you should be fulfilling when you're providing the medications directly to the patient. And the other thing that's been missing in every kind of guidance everywhere, so it's lovely to have it in the therapeutic guidelines, is how to obtain stock for your practice. So again, Annie, you probably know that dentists, even if they don't have a full dispensary of drugs there in the practice, they like to have some to administer to the patient, like that one tablet of temazepam or that one, or the antibiotic prophylaxis that the patient forgot to get dispensed or forgot to take before they came in.
That's
You
a
can
common
have
one.
a stash of that in your practice, but how do you get that? And what a lot of dentists erroneously think is that they write a script for that. And that is not what you do. So therapeutic guidelines have explained that quite clearly, that the prescription is only for when you're providing a message to a dispenser to give some medicines to the patient to take home, and it should be for a named, a specific, real named patient. Because what some dentists do is they put a fake name on the script, or they'll say the clinic, who is not a person, or they put their own name on a script in order to get this stock for the practice. So yeah, it's wonderful guidance to say what you really should do, that it's fine for you to have stock in your practice, but what are the regulations about that? And then finally, they've got pictures of prescriptions. How good is that? So,
That is
and
good.
not just for a PBS prescription, but for a private prescription, a so-called non-PBS prescription, and what an adult prescription looks like versus a pediatric prescription, and then how you write the prescription for drugs of dependence.
That's fantastic. That's so comprehensive. And
It's
I'm
terrific.
really pleased to hear that because there's a whole load of things going through my mind as we're talking. You probably saw me wince when you said about people prescribing for themselves. I was like, oh, we never do that. Oh, but I agree. People would innocently do that. And,
Yes.
because you've rightly said, to get the stash that you need for those patients who forget, for example, their antibiotic prophylaxis, but
Yeah.
there are some quite strong rules around how we who we prescribe for, and not prescribing for ourselves is one of those. And of
Yeah.
course, we have to prescribe for the purposes of dentistry. And I know that that catches people out with friends and family members saying, I'm going
Yes.
overseas. Can you just write me up a prescription for?
Mm.
Or I've run out of my medication for my heart tablets.
My cholesterol.
Can you just do me a solid? No.
Right. And again, like it's rarely ever specifically mentioned in legislations, but therapeutic guidelines has got that about prescribing for self, family, and friends, and what the limitations are around that.
Yeah, and I think that's really good because often, more often than not, these things are quite innocent, both the asking and the doing, but the
Yeah.
consequences on your registration can actually be quite severe. So I'm glad that someone is highlighting that. I did love when you get the book, read it. I did smile. Imagine that. Everyone going, wow, a new clown book. Let me just put it on the shelf.
And
Wow,
there it
it's much bigger
stays.
than the last one. They must be using bigger print. Okay. So that was the beginning. Where would you like to go next?
I'd like to go to analgesia.
I would love for you to go to Analgesia.
So not much has changed, but there's a more extensive section on the risks and benefits of various medicines. The usual stuff is there about the pivotal role of paracetamol and ibuprofen, or any sort of typical old-fashioned conventional non-steroidal anti-inflammatory drug, NSAID for short. However, there's a little bit more guidance on understanding safety and in which patients they will be absolutely contraindicated. That again, I wrote this section in conjunction with the editors at Therapeutic Guidelines. So we were meticulous in sort of making it clear for whom an NSAID is absolutely contraindicated. You cannot do it. You will kill them. Because because that's, before it was like use with caution, and I hate that expression because it doesn't mean anything. It sounds like you tippy-toe or something. And writing a prescription and tippy-toeing at the same time would be very difficult. So there's more on the role of coxibs, specifically celecoxib. If anyone's interested, I just wrote an article for Australian Prescriber in August this year. Well, that's when it was published, entitled "The Role of Coxibs in the Management of Acute Dental Pain," because I think people kind of know those drugs are there, but they don't really know when and why and how to use them. They're not on the PBS for dentists, but that doesn't matter. That's just how they get paid for. That you legally are allowed to prescribe them, especially because they would be used for a dental purpose. But they're another string to your bow when you're managing those patients who'll say, well, I know you think I should take paracetamol and ibuprofen, but I can't take ibuprofen. It upsets my stomach. And, often they've, had a bad experience 25 years ago and it wasn't even ibuprofen or whatever, it's unlikely to be real. But rather than arguing the point, you can just say, we've got these other drugs, this one in particular called celecoxib. It's been specifically designed and available for us to use in people who do complain of gastrointestinal upset because it doesn't even touch your gut. So it's perfect for those people, and also for people who think about any NSAID and asthma, which is a bit of an urban myth anyway. But again, rather than having the argument you just gave, these ones are safe. And also people who get aspirin-induced other airway disease, which is usually like hay fever. However, there's still a problem with people with kidney disease. So, you can't give them to everyone who's got a problem with NSAIDs. There's a further emphasis on the diminishing role of codeine in managing dental pain. Should we quickly talk about that?
I would love to, because obviously, so bearing in mind my role, I see when things have gone wrong.
Mm-hmm.
No one ever rings me up and goes, Annalene, I had this amazing procedure that went really well today, and the patient's thrilled.
Wouldn't that be nice?
I know, right? So I always get the worst stories when everything's gone wrong. And a common theme that we see is inappropriate. And by inappropriate, I mean patient has postoperative pain and they complain that the pain has not been appropriately managed, i.e., I'm still in heaps of pain. And so what happens is they get Panadine Forte or whatever type of drug with the codeine in, and they're having to take quite large amounts. They're not getting the effect. And then they're getting, you talked about gastrointestinal issues, they're getting constipation, they're getting other issues which are making them miserable. And then the dentist will flip and then give them, say, endone, which is, and we've had patients who've then tried to drive or had accidents or had, I see you, that was your wins.
Yes.
Or who've tried to go to work or not known they couldn't work. So you can imagine if you're a patient, right, and you've had a difficult extraction. So first of all, you've had a bad day out. That's no one's fault. It's sometimes teeth are hard to come out. If it was easy, everyone could do it. Okay.
Yeah.
So you've had a difficult extraction. In your mind, that's, already a trigger. You've had a really bad day. Then you've had a bad night. Your pain's badly controlled. You're given a medication which makes you sick. And then you're given another medication that you didn't understand the severity of. And then you can't work or you do something stupid and you're still in pain. So in an outcome that will surprise no one, those patients then complain. So yes, I would love to talk about it for that reason.
Terrific. So I guess it sort of harks back to people having this blind faith in opioid medication, that they think it's a strong medicine and therefore would just get rid of strong pain. So, like in the first place, we'd say, please don't use those words. There's no such thing as strong drugs. There are just drugs that do different things. They have different mechanisms of action, but there's not one that suddenly has big muscles and will go in and do the job. And opioids do not manage every type of pain. We also should avoid the word painkiller because it gives patients an unrealistic expectation for the degree of pain management. So we should talk about pain management so that they understand they may not get zero pain as their outcome, but also understanding the limitations of opioids. So that's the first thing, is that most dental pain, most of the things that people come to you to manage is inflammatory in nature. So either that, like infection, but also if people have got post-op pain, it's due to tissue trauma, and that's inflammation as well. So we want anti-inflammatories as the drugs of choice. We throw in paracetamol because it's, so easy to use, it's safe as houses, even in pregnancy, but we won't go there.
Yeah.
And
Oh, topical.
TGA's put out a lovely statement about paracetamol in pregnancy, by the way, that just came out today, very clearly states that they and other drug regulatory agencies around the world oppose the notion that paracetamol is unsafe in pregnancy. How good is that?
Yeah, I saw that actually, and I
So
did think it
clear.
was well written.
Yeah, so if dentists need to argue with anyone, just give them that statement from the brand new statement, because the previous statement from the TGA on like the day that the American government was saying things was a bit wishy-washy, but this one is really outright stating a fact. Anyway, so we want anti-inflammatories as the drugs of choice because we're dealing with inflammatory pain. Opioids do nothing for inflammation. So you can take the whole box if you like, but it's still not going to address the underlying
But please don't take a
pathological.
whole box.
But don't. Yes. Quite dangerous. So it's that blind faith thing. So and a misapprehension that if the patient's struggling now with the first drugs didn't work, oh, what do I use now? I want the strong drugs. That's not how pain works. So secondly, codeine is just a dumb old clunky drug. And I predict that in 10 years, maybe even 5, we won't even have it on the market.
Do you
And the
think?
reason, yeah, so the reason, as I'm sure you know this already, is that it's a prodrug. So it has to be converted to its active
Yes.
form to work at all.
I did know that. I
Yeah,
know,
and
Sherlock.
it's and the active drug is
Don't push me,
morphine.
Terry.
It's just morphine. It's morphine in disguise. So
Okay, yeah.
but there's still so many dentists out there prescribing codeine without realizing that the drug they're really prescribing is morphine.
Yeah.
But it's not morphine in the form that we swallow. It has to be converted in your liver. Now, that step is performed by an enzyme that not everybody has. And we don't wear a T-shirt saying, hello, I can metabolize morphine, codeine to morphine. The enzyme's called CYP2D6. And I know I've got plenty of it because I can convert codeine to morphine because I can take some and be asleep and get constipated all in the first dose. But other people take codeine, as you probably experience yourself, Annie, with your patients, take codeine and say, well, that did nothing, because they couldn't. And in its pre-converted state, it's called 3-methylmorphine, that's the technical name for codeine, does not bind to the opioid receptors. So unconverted codeine does not work, doesn't do anything for pain. However, it will still constipate you and cause drowsiness. So it's different receptors, different opioid receptors. So that's the second thing, is that it doesn't work for everyone because they can't convert it. Third thing is it might not be a pharmacogenetic reason you can't convert it. It might also be because you're on other medicines that block the conversion of codeine to morphine. And I reckon if they tried to put codeine on the market now, it just wouldn't get on the market because they go, well, this is stupid. We can't predict who this drug's going to work for. People have to think too much to work out who it might work for. Besides, if you take a 60 milligram dose of 2 Panadeine Fort tablets or 60 milligram dose of codeine, that only turns into about 8 to 10 milligrams of morphine, and that's not very much. Yeah. So people have always thought of it as a, what do they call it, low potency or low mild opioid. Again, no such thing. It just was a low dose. So what we'd rather people do is prescribe a drug that the drug you swallow is the drug that works, and that's oxycodone. Endone. There are other brands available now too, but oxycodone is the drug in it. Now, actually, when you look at them pharmacologically and in therapeutic settings, they're ultimately pretty much the same degree of efficacy, provided they're prescribed in equally analgesic doses. So neither is stronger than the other. But what's lovely about oxycodone is that it's got very predictable pharmacokinetics. It gets absorbed well. It doesn't need to get converted into something else to work. And when it's metabolized and excreted, it does so in a linear fashion, doesn't accumulate. It has a reasonably longish half-life of 6 to 8 hours, whereas morphine only lasts for about 3 hours. Yet we prescribe Panadeine Fort every 6 to 8 hours, probably 6 hourly, but the patient will lose their analgesia after 3 hours, and then the rest of the time they're going, the drug's not working. So we want a drug that's more reliable, more efficacious, more with a better duration of action than silly old codeine. So that's why we're trying to tell people don't use it. But even if you did prescribe oxycodone, generally it's not needed, as you said, because for most people, the inflammatory pain will respond beautifully to ibuprofen and paracetamol.
And I think patients just need that reassurance because what you're saying about that strong drug and mild drug and weak, for a patient's perspective, they're having some pretty strong pain, okay?
Yes,
And they may or may not have tried to take some Panadol or ibuprofen or whatever, and it's not touched it. So I
yes.
think they need that reassurance again about, yes, this will work, why it will work, and
Mm.
how to take it as
And they
well.
should say, "And it's so effective. Come on, give this drug a go." Because we don't
Yeah.
it's a bit of an academy of award performance that we're required to do because people can buy ibuprofen in the blooming newsagent or the supermarket. I think in many ways, we as health professionals assume that they know these drugs really, really work, but a lot of patients think they don't because they think if you can buy them in a supermarket, they must be pretty namby-pamby.
Yeah.
But also, they do occasionally hear that they could be dangerous. So they don't have much faith in these drugs working. The other thing that people do is they take them with food. And that's a message I've included in a lot of the lectures I've given around the trust. So a lot of people would have heard this, but we've got to make sure the patients take it away from food so that the drugs get well absorbed. If you take ibuprofen with food, it reduces the maximum absorption by about 30% and delays the onset by about an hour and a half. Same with paracetamol. So no wonder they're going, "What's the drug doing? It's not working," because the food stuffed it up.
Yeah.
And they're only doing that because everyone says take it with food. But if you actually look at the manufacturer's advice, they say take it with water. No one in the sort of the regulatory areas say take it with food. And we know now from lots and lots of research that food does not improve the safety. So taking with food is just us thinking, when we say it, we go, "God, I'm good. I've told them to take it with food."
Yeah.
You're just perpetuating a myth. So if we can make
Yeah.
sure they take it away from food, take the right dose, know what they're taking, because that's another issue with health literacy is people hear these drugs all the time: Panadol, ibuprofen, Panadol, Nurofen, ibuprofen, aspirin, Nurofen. They think they're all the same thing. So I've had people who said, "Yes, I took that paracetamol and ibuprofen, like you said," but they took Panadol and Panadol because they actually didn't know the difference. So when you
Yeah.
get those patients reporting the drugs didn't work, just take a bit of time to ensure you've checked what they actually took. Bring the boxes to the phone, read it out, tell me what you actually took. Make sure they took the right dose. From time to time, bumping up the ibuprofen dose can add a little bit of extra efficacy.
Yeah.
Also, just some people will respond to one NSAID better than another. Like my
Yeah.
husband prefers uh, diclofenac or Voltaren over ibuprofen, and that's because our cyclooxygenase enzymes that the NSAIDs inhibit are C-shaped, and the drug's got to go inside that C. And we all make our C-shapes a little bit differently, so trialing a different NSAID can also be another way of improving the efficacy. And then once and of course taking them simultaneously, because a lot of people still do the alternating thing. Oh my,
Yeah.
so
Which is what
20th
we were
century.
taught. I mean, bearing in mind I'm old, but that's what we were
Older.
taught, this idea is that one was wearing off and the other was
Yeah,
kicking in. So I can understand why, but this is also why it was important. So that's what was believed 25 years ago,
yeah,
but that's not correct, and that's
no,
okay. But
yeah,
that's why it's so important to stay up to date because you could be working off quite old knowledge
that's right.
genuinely, but actually we know differently now. Can I ask you a question?
Mm.
You can buy medications now that have got ibuprofen and paracetamol in the one capsule. Do you have any particular view on those?
I think it improves adherence for some people. There's therapeutically, you'll still get the same benefit from 2 ibuprofen tablets of any brand and 2 paracetamol tablets of any brand, and just take the all 4 together. By the way, people do wonder why the TGA has mandated that some brands take 1 of those ones with the 2 drugs together, and that's simply because one 500 milligram dose and one 200 milligram dose of ibuprofen taken together achieves a lot, about 90% of the effect. When you take the double dose, it's only about 10% increased. So the TGA went, "Fantastic. Here's a way of getting great analgesia, but a much lower dose." I don't know. I sort of think to boost that chance of getting good analgesia, go the double dose to begin with, and then you can bring it back as you go.
And then he's back.
Yeah,
Yeah.
but you've got those people, if you did tell them to take 2 Panadols and 2 Nurophens, 4 tablets, they go, "Oh, that's a lot of
So many
tablets. I'm gonna
tablets.
shake or rattle when I walk." And I never laugh at that joke. But every patient says it, and you go, yeah. Anyway, so some people just will not take 4 tablets. So to improve adherence and so they don't freak out about the number of tablets, especially if they're expected to take 4, multiple times during the day, by putting them together, you maximize the chance that they'll take the right dose, and then also improve the chance that they'll be taken at the right time, because some of the brands have got an ingredient in them and a formulation that allows the paracetamol to dissolve a little bit before the ibuprofen, which improves the chance that they'll be synergistic.
Oh, that's really interesting.
Yeah, but I don't think it's magnificent that you spend that extra money. But I certainly think for those people who go, "Oh, I don't like 4 tablets," it's a wonderful invention.
Absolutely. But you touched on a really important fact, of course, which is cost. Because the
Mm.
reality of it is you can pick up a generic paracetamol and a generic ibuprofen reasonably
Oh, yeah, $2.
economically.
Yeah. Mm.
Yeah, as you said, from a whole variety of places.
Mm.
So it's that convenience in a different way as well. But no,
Yeah.
that's really helpful. Thank you for
Can I just
revisiting
mention
that.
one last thing? I gave a seminar on pediatric prescribing in dentistry about a month ago for the ADA,
Uh-huh.
and a lot of people asked about, well, is there going to be a pediatric formulation of combined paracetamol ibuprofen? And we've all been crossing our fingers hoping, but the manufacturers are all a bit too chicken to do it. As you
Mm.
know, running clinical trials in children is hard to do anyway, and most parents are not keen to put their children into a clinical trial. They also just struggle with the idea of having to put these really old drugs, tried and true drugs, through the whole registration process through the TGA. So I would not be holding my breath that there will ever be a pediatric formulation of combined ibuprofen paracetamol, unfortunately.
Yeah, no, thank you for that. And you raise again a really interesting point. It's my understanding that a lot of drugs have not been tested, as in gone through clinical trials on children or women. But what happens is you build up that bank of knowledge where it's been used safely for X number of years, and that's how we know it's safe. Is that correct?
Not entirely, no. That's changed in the last sort of 5 to
Okay.
10 years, because we were therefore calling women, and especially women in their childbearing years, and children, therapeutic orphans. So in about 2005, we did discuss this in the seminar we held last month, that it took legislation originally through the FDA, but also other regulatory agencies band together and said, we've got to fix this. That firstly, when new drugs come on the market, that they need to state clearly whether the drug has been trialled in children, and they should establish some process. So what they do is called population pharmacokinetics, and they have databases and registries that now collect data from individual patients who are being given these drugs, even if they're pregnant women, breastfeeding women, just women, and collect that. Frankly, women are being included in clinical trials now. It's been well established that that's silly to not include women. But for children, they're now using these other methods whereby data is collected, but then it's accumulated, and then statistically they work out, they get the data, and then they find the line of best fit, and they can then say this is sort of like a pseudo clinical trial.
Yeah, no, that's fantastic, and I'm so glad to no longer be a therapeutic orphan. I do smile, because you know how your social media, you're very much targeted by, your algorithm targets you. I
Yes.
get loads of amusing content about research in menopause not having been
Oh, yes.
great and that type of stuff about, being a therapeutic orphan, I guess, and
Yeah.
and people not necessarily, but you're quite correct. It is a nonsense to try
Yeah.
and yeah,
Yeah. So pretty
absolutely
much
nonsense.
all clinical trials now have to mandatorily include an equal percentage of women. And because, like, how dumb is that? We're half the people on the planet. But also, due to this high promotion of the lack of research into menopause and also endometriosis, there's just so much funding going into that now. And there's even brand new drugs coming out to treat both of these conditions, which is great news.
Yeah, that is great news for at least 50% of the population.
Yeah,
That's
at last.
okay. So analgesia, is there anything else you wanted to touch on with that?
Yes. So
Brilliant.
I used to still get a lot of questions about tapentadol. There are a lot of dentists who want to play with this new toy because I
Yes.
think they see,
We've
yeah.
talked about this before because I hadn't heard
Mm.
of it.
So Palexia is the famous brand, but there's a couple of other generics now. What people need to understand is that it's nothing new. It's no better really than any other opioid. They're largely all considered equally efficacious as long as you prescribe them in equally analgesic doses. But what differs are their side effects and their risks for interactions. Now, what people tell me about tapentadol is that they just want to be sick the whole time they're taking it. So it's just like being on Ozempic. Uh, not that I'd know. Or Minjaro. Um, but no one wants to be vomiting when they're also in pain. It's counterproductive. So that's about 20% of the efficacy of tapentadol is that it's like a noradrenergic antidepressant. Now, that may help it be efficacious for treating neuropathic pain, but 80% of the effect is through opioid receptor agonism. So our big trick, though, is that it can be a new string to your bow. It can be useful in those patients who go, nothing works for me. I must have another drug. Get me another drug. So you can whip out tapentadol. So legally, dentists are allowed to prescribe tapentadol, but not in Queensland. We have a fixed list of the drugs of the controlled drugs that dentists are allowed to prescribe in Queensland, and it's not there. However, in most other states, they are allowed to prescribe it. In New South Wales, their rules legislation about controlled drugs is that opioids for dentists can only be prescribed by hospital-based dentists. And so ones out in the community can only prescribe those listed on the PBS for dentists, and tapentadol is not on the PBS. So that means for any dentist around Australia who wanted to prescribe tapentadol, the patient will have to pay full cost. And they're not cheap. They're about $75 for a packet of 20 tablets. Yeah, so consider those things before leaping to the prescription pad. But also, it's just an opioid, so it's not going to do the anti-inflammatory thing we mostly want for good analgesia. But the therapeutic guidelines does have a very fine print down the bottom. It's not mentioned in the usual list of drugs recommended. We've got the typical paracetamol, ibuprofen, consider another NSAID. Then you can think about celecoxib. If you need an opioid, we prefer to use oxycodone. And then in tiny print down the bottom, it says, yes, you could think about tapentadol. But the risks they worry about would be if it's for a patient who's already on another antidepressant. And so there are significant adverse effects that could start within seconds of that first dose, lots of drug interactions, and also the risk of QT prolongation, which most of us don't worry about too much in dentistry. So they want you to consult with the patient's medical practitioner before putting pen to paper and recommending or prescribing tapentadol for your patients.
Yeah, no, that's really helpful. And I think you've touched on a very important because, of course, our listeners are Australia wide. I'm based in Queensland. So what I can do, according to my Drugs and Poisons
Mm,
Act, is different to
yeah.
what someone in Northern Territory can do, is
Mm.
different to what someone in Western Australia can do. And it's really important that you are aware of where to find your guidance and what the rules are, because you might hear that someone in a New South Wales hospital is doing something, but that doesn't mean that you can. So I think that's a really helpful point to tease out as
So
well.
if you have electronic access to therapeutic guidelines, the legislation for every state is listed there, and you can just click on the hyperlink, and it'll take you directly to the legislation. And then you can just do a find of what can dentists prescribe in
Yeah.
each legislation. That's really a point, isn't it? Because now that we're nationally registered, theoretically we can all work anywhere, but the legislation varies so much between states. Oh, I remember one other thing I need to say about tapentadol, and that is, and this is a pharmacy thing, the lowest strength available is a 50 milligram capsule. Actually, it's
Uh-huh.
available as immediate release and sustained release.
Uh-huh.
The 50 milligram dose is equivalent to 10 milligrams of oxycodone. So that is like 2 standard endone tablets. So even the lowest dose of tapentadol is a high dose. And that's
Yeah.
actually why I don't like it. I think that's a
Yeah.
clumsy thing to prescribe to people. as if you'd give 10 milligrams to endone to someone who's never had an opioid before. You'll give them, what do you call it, when you overdose on opioids, and you'll give them an overdose, but also
Yeah.
all the side effects.
Yeah, that's a really good point to raise as well. Thank you. Now, antibiotics.
Right. This is
Probably, so we've talked about this before. My prescribing pad's got moths that come out of it every time we open it. And
You've
on the
seen that.
very rare occasions I do prescribe anything, it is almost always if I do prescribe antibiotics. And that's because I don't do complex surgical procedures that necessitate the level of pain management that we're talking about.
Yeah.
Okay. But
Mm.
obviously, I do things, I do treat infections. So you said there were some big changes. And is this a section that you worked on as well, or just something you're aware of?
I contributed to the discussions, but they really, this happened last time too. We made our recommendations, all of us, and they kind of took it away and had it edited by the people who contributed to the Therapeutic Guidelines Antibiotic Guideline.
Uh-huh.
And so it came out rather changed, to which we didn't have much contribution. It was a
Okay.
bit interesting.
Is it still
So,
meaningful for us though?
well, it was a surprise.
Oh, surprise.
Yeah.
I feel like that often when I open these books to be on, oh, the
Yeah,
what
yeah.
now?
Well, at the discussions, we were all told that for patients allergic to, claimed to be allergic to penicillins and cephalosporins, no, sorry, just penicillins, that the new drug to recommend would be cefuroxime.
Yep.
And that's not there. It's not the case. So that's the big surprise. You still could prescribe that, by the way, because it's got a similar spectrum to amoxicillin, but shares no side chains. So there's no chance of cross reactivity. So if your patient has a legit, true amoxicillin allergy and they never want to take that drug ever again in their life and they're fearful of cross reactivity, you can say, well, this one doesn't share any part of its important part of its chemical structure, which is the side chains. With amoxicillin, it will be fine and won't trigger your known allergy. I mean, bad luck can happen and you turn out to be allergic to that too, but that's not a cross reactivity. That's just you're allergic to two drugs. So the new things would be they've broken down how to treat acute odontogenic infection down
Okay.
into steps. Now, you may remember from the third edition, the antique version you've got in your hands there.
I love my clown book. Don't take my clown book away from me. Even if it does end up being a huge, great big book, I'll still love it. I know that you all think it's cute that dentists like their book, but like we really do. Like I'm even
Sure.
clutching it to my heart.
You go to sleep with it at night.
Something like that. So anyway,
Yeah, so
back to my
anyway,
antique copy.
as you probably know, in that edition, they got rid of the first step where you could just prescribe a single antibiotic for acute odontogenic infection that looked like it might be spreading, but there were no signs of systemic involvement.
Yeah.
Most people just used to prescribe amoxicillin.
Yeah.
That was in the second edition. In that one, they got rid of a single antibiotic. They said the spectrum of amoxicillin is not adequate for that. And so the
Yes.
step one of treating an odontogenic infection in that book says use amoxicillin and metronidazole. And we
Yes.
were blindsided by that. We're like, how can you go from 0 antibiotics to 2?
Yes.
Nevertheless, they wouldn't change it, and we've been stuck with that for 6 years.
Page 80
There
on the
you
antique
go.
copy.
So we've gone back. So in the fourth brand new edition, we've gone back to having a single agent for that initial infection where you can tell it's truly really infected, but you want to use just one antibiotic. And it says amoxicillin as first line or ampicillin if you want to be an excellent antibiotic steward. For patients claiming allergy but a non-severe allergic reaction. So here's where dentists will have to spend some time becoming familiar with the terminology of severe versus non-severe, immediate versus delayed allergic reactions, because they're managed completely differently. So if you've got a non-severe, immediate or delayed reaction, so like a namby-pamby rash that, is no big deal, it's just unattractive, they said you can give cefalexin. The risk of there being cross-reactivity is so low, it's just silly to be going to clindamycin.
Uh-huh.
So they want you to use cefalexin, and then but if the patient has had a severe reaction, Stevens-Johnson syndrome or some horrible sort of all over the body urticaria, or even if it were severe asthma, then, and it's allergic asthma, then they go, sure, absolutely, just ditch anything related to penicillins or cephalosporins and use clindamycin. So they've got it listed now as acute odontogenic, actually, I've got to put it out, where if dental treatment is prompt, but without severe local or systemic features. And then they've got without severe local or systemic features if dental treatment is delayed, and different recommendations for that. Oh, they've also got, in that one, they'll have amoxicillin and metronidazole or augmentin, then cefalexin, then clindamycin, and then severe local or systemic features but without sepsis. And then they've got the IV drugs, and then they've got if there's any suggestion of sepsis, and that's when they want you to panic and call the ambulance and send the patient to hospital. So they've I think it's great. It's much more nuanced and reflecting real life, I think. And
Yeah, it's
also
good it's
maybe more
graded.
useful for those people working in regional or remote areas where they go, oh, well, there looks like systemic features. I better send you to hospital. Oops, there isn't one for 1,000 kilometres.
Yeah.
Do you call in the Royal Flying Doctor Service? They're now saying this is what you should do. They're also making it clear that you shouldn't just expect the patient can romp up at their GP and get an infusion of a benzopenicillin. Because, many GPs don't know how to set up an IV infusion.
I didn't know
Or don't
people
have the
did that.
equipment. It's a nursing thing, isn't it?
Yeah, I didn't know people did that. That's fascinating. Okay, well, I look forward to reading that section. One thing I do like, and we probably discussed this before, but I love me a table and a picture and something that, like, that idea of this goes to this goes to that, and that's why I love a book.
Yeah. They've got a really lovely a new flowchart about managing your patient with a claimed allergy to help tease out how you're going to describe this claim of allergy. So they've got, like, for example, those patients who say my reaction was when I was a baby,
Yeah.
or I only ever had diarrhea. That those ones you can just straight from the history you can say that's not allergy, or even if it were, it's so long ago that it's unlikely to be real now. But they also say, they're still fretting about it, and refer them for testing, because that will be the absolute definitive outcome to say, yay, it has actually worn off. Because people don't know that allergy is no longer considered a lifelong affliction, do they?
No, and I remember we talked about this before, and I'd certainly not heard about it until you raised it, that people can be allergic to penicillin as a baby or as a child and then mature past that. I thought that was quite interesting because it's certainly I'd never heard that before you
Yeah,
told
it's
me.
just a complete change in everything and how we approach the whole thing. But the other area where managing infection risk has changed, and I'll mention it now, even though it's not treating acute infection, it's about antibiotic prophylaxis. And
Okay.
so the recommendations here are a bit different. I mean, you've got the standard amoxicillin 2 grams for most patients, but then they have 2 grams of cefalexin as your next step, as we did with the treating an infection. But for people who claim they can't take a penicillin or a cephalosporin, clindamycin is fourth line, and the next step is actually azithromycin or doxycycline.
Okay.
Yeah, and we really haven't used. I mean, the azithromycin has obviously been used in periodontal disease, but not
Yes.
for prophylaxis. I know a lot of dentists are aware that it's being used as prophylaxis in the States and in Canada, but we didn't want to go that far with dentistry because there's huge issues around the world with resistance to azithromycin. Plus, it's got potential drug interactions and adverse effects, as lots of people know. So we'd certainly say use doxycycline first as your option for those people complaining of a lot of allergies. And the dose in adults is pretty straightforward, as 100 milligrams, but the dose for children depends on their weight. So there's 4 different categories for that. So people really do need to consult the guidelines. Now, the next thing people will say is, you can't use doxycycline in children because it will discolor their teeth. You're right. But there's some actually really good research evidence to show that if it's used for less than 2 weeks, there is no risk of discoloration. So, it's a true single dose for antibiotic prophylaxis. That single dose will be fine in children, even little
Oh,
kids.
well, that's really interesting and also very reassuring. Thank you. Anything else about antibiotics you wanted to touch on?
No, that'll do. Just read it. It's very detailed and it's very different from what we've had written before.
No, that's fantastic. Yeah, no, and it sounds like it's been very thoughtfully put together. So, one thing that I've actually spoken with you about previously, and I've just opened up my book, the antique version 3.
You do love that book. And good on you. It's well thumbed, I can
I
tell.
also have version 1 and 2. And I see what
Oh.
you're saying about how they've got bigger and bigger. Well, that's actually for a different reason, Joe, because what you need to, I guess, in fact, I'll go to local anaesthetic because that becomes pertinent for what we're just about to discuss. And then I'll pick
Uh-huh.
up on the green whistle. When you do treatment and say there's a clinical incident, a lot of it depends on what the guidance said at that time.
Yeah.
Right. So if the guidance said, for example, you could not use articaine for blocks. So this is something which is a shock to a number of dental practitioners, I find. The one in my hand, the antique version 3, says on page 205, articaine, risk of prolonged or permanent anesthesia for infiltration only, do not use for regional blocks. And then it opens a bracket and it says injection close to the inferior alveolar, lingual and mental nerves. Close bracket. Do not use in children younger than 4 years. So what that means is if in May 2025 you had given a block with articaine and the patient had prolonged paresthesia, the cause of that more likely than not is actually the trauma of the needle.
Mm.
But if you had used articaine, regardless of what you've read anywhere else, you would have been contrary to the therapeutic guidance at that time. So the reason that I have a whole load of these on my shelf is because when we have something like that and the patient says,
Ah.
I've got a nerve injury, you gave me a block in 2015, we have to then go back and check and see what the guidance said at that time to see whether or not you were working inside or outside the guidance at that time, because that impacts on the defensibility. Does that make sense?
Yeah, terrific. Yes.
Yeah. So it's not just that I hoard books like Smaug the Dragon,
It's a bit
although
of
there
that
is a
fun.
touch of that too. There's actually a dentolegal reason for that.
Yeah.
Now, some people will be reeling to know that in version 3, it said no articaine for blocks. My understanding is version 4, I know this isn't a section that you worked on, but my understanding is that version 4 is not as restrictive in its position. Is that correct?
Yes, that's absolutely right. The new edition simply says that since publication of the last guideline, there's been a lot more information published, lots more research, and re-reviewing of the literature. And it's now expert opinion is that the risk of nerve damage and other sort of post-operative complications is much less than previously thought. Now, they don't go so far as to say, therefore, you can use it as much as you like. Because I think the people at Therapeutic Guidelines were loath to say you can or can't do anything. They're guidelines, not tramlines. And that's another important point, isn't it? That if you can substantiate what you're doing despite the guidelines saying a thing, because other sources of evidence do exist. Indeed, there are other guidelines. Then that may be sufficient, and all of that new research that's come out since the last edition would help substantiate your process if you were working outside the therapeutic guidelines, but you'd read all these other research papers that said, what are you talking about? It doesn't really cause that neurotoxicity all that much, or that it can, but it's extremely rare. Also, sometimes guidelines simply reflect the membership of the committee at the time. And so the new membership of the committee were very keen to downplay that risk. They all use articaine. They all think the risk is tiny. They do say it's real, but it's tiny. And so they
Yeah.
wanted to make people feel more encouraged to keep on using it.
And as I said, my understanding from the work of Tara Renton, Associate Professor Tara Renton, I don't know if you've ever come across her. She's worth a look. She's an expert on nerve injuries
Uh-huh.
and though genuine nerve injuries where the patient can't get better.
Mm-hmm.
And she has some published research on this, but she talks about the trauma of the needle as well and I can tell you anecdotally at Dental Protection, we don't just see paresthesia from people who've used articaine.
Oh, there you
If it's a
go.
traumatic event, it's a traumatic event.
Right. Whereas, on
Um,
a writing committee, we'll have some people going, well, I've had to look after those patients who've got it after your articaine and, they're completely convinced because they've had a case. And
absolutely,
that's the problem with
absolutely.
guidelines is it's just reflecting those individuals and their
Yeah.
experience.
But we see it from trauma, I guess is what I'm saying. We
Yeah,
see it
yeah,
from
absolutely. And I think they say that in this new edition as well, don't they? That
I
trauma
don't know,
from the
Jerry,
procedure
you've seen
itself,
it. I
um,
haven't.
I had a look just before, it contributes to that risk. Absolutely.
Thank you. Now, I wanted to talk about where I started to go and then jumped back. And I know, I wanted to discuss this was the green whistle.
Mm.
So methoxyflurane. So commonly we call it the green whistle for obvious reasons. And again, it's been a shock to a number of members who've rung up in the past, where it said on the antique version, page 214, methoxyflurane is not recommended for anxiolysis for dental procedures. So was not recommended to treat anxiety. Now that I think came as quite a big surprise because a number of practitioners quite like the green whistle. And I know that when my son recently dislocated and fractured his elbow in volleyball going for a
Oh,
dive, and you'll be pleased to know, very important, Geraldine, he did get the point.
phew, I'm so
I
glad.
know, I know. And he was at great pains to tell the ambulance driver that. But he was given the green whistle, and I could see how effective it was. So I wondered if this position has been revised, considered, reviewed in version 4, or if it stayed the same.
No,
I
it's
just
not the
wondered.
same. So definitely reviewed. Can I just say your son got benefit from methoxyflurane because it's analgesic,
Yeah.
but it's not an anxiolytic. So they do make the point in the new edition that it's not an anxiolytic drug. It's not like inhaled Valium. It's a inhalational anesthetic. So it's actually related to the general anesthetic gases like halothane, enflurane, sevoflurane, that are the gases that an anaesthetist would give you after induction to keep you asleep. So that's what this drug does. It puts you to sleep. That's not anxiolysis, is it? But it also has some analgesic pain relieving effects. So bloody brilliant for the ambos to use for people with broken things. My daughter, when she was 7, completely severed her radius and ulna and her forearm from falling off the monkey bars. But oh my God, the pain because the ends of those, yeah, it was horrible. And she didn't actually like the taste of it, but that's what its role is for the analgesia. And so the committee wanted to say that's what its role can be in dentistry because a lot of general procedures can be painful. People fret about the pain. So if you can manage that pain with this inhalational device, that's a good thing. So certainly they have gotten rid of that statement about cannot be used. It can be used, but it's not anxiolytic. So, it's like say we were going to use, I don't know, fentanyl or heroin to just relax people. It's over the top because this is a general anesthetic drug. So they've put a lot of caveats around its use to say if you're going to use it, it should only be used by people who've got training and competence in the use of this drug. So don't just use it because you say, oh, my friend down the road uses it at his practice. I think the problem can be because it's given or supplied as a whistle, it trivializes this product. So people think it can't be anything serious. It's a very serious drug. So first thing you need to be trained and have appropriate knowledge and experience and competency. Secondly, they want you to have all the equipment necessary to manage any acute adverse reactions, and those include malignant hyperthermia, which is a risk with all of the inhalational anesthetics. So you need to not only know where you would get the antidote to malignant hypothermia, but also know how to recognize malignant hypothermia if you saw it. And be aware of other adverse reactions. And the biggest risk I see with dental patients is liver toxicity. There have been quite a few documented cases of people developing liver damage or, being admitted to hospital in borderline liver failure. Also, very much suppression of breathing. So you need to third thing is to have the appropriate equipment to monitor your patient as you would with any sedation. And the bare minimum being, pulse oximeter, but also other monitoring to make sure if the patient stops breathing, And fourthly, sufficient staff, because you are sedating your patient. And therefore, and also to consider things like polypharmacy. So don't use the green whistle and some Valium and some nitrous and whatever else and some opioids that you're just going to kill people. So I'm being silly, but there are lots of risks associated with using this drug. But if you're trained and if it's sufficiently experienced and you've set up your practice to manage the risks, then the guidelines say that's fair enough.
And I think, thank you, because I hope that that explanation helps colleagues who perhaps haven't been considering how and why we use the green whistle, helps them really reflect on the things you need to be thinking about. So,
Yeah.
Jerry, thank you for your time. My takeaway from this, other than read the guidance, which I think would be sensible, is I always feel that when we talk, we as clinicians really need to think about what's the problem I'm trying to address here? Pain, for example. What's the cause of that pain? Inflammatory, for example.
Mm,
Therefore, I need to use an anti-inflammatory agent here, not
mm.
a strong painkiller. And so I think that that's a really helpful thing to remember, is that think about what we're trying to achieve, and then we'll choose the correct tool. Would you say that that's fair?
Yes, absolutely. And along with that, educate your patients to understand those steps as well, because people, general public consumers that haven't learned pharmacology, we don't teach pharmacology at school, think there is such a thing as a strong painkiller, and that all pain medicines just take pain away. Yeah, so it's not only making sure we're aware of those steps, but having our patient come alongside with us at the same time, and
Mm,
that's the basis of shared decision making, isn't it?
absolutely. And we've all been guilty of that language, I think. So, is there anything else before we part ways that you feel that we need to share with our colleagues today?
Just one quick thing. There's a brand new section added to the section called managing uh, the dental conditions of patients with or the dental issues with patients with medical conditions.
Right, that sounds helpful.
Now, previously that was, a reasonable section, but not particularly lengthy. It's now enormous. It's terrific. It covers
Good.
so many things. This is where management of patients at risk of ONJ is located, but also your patients with diabetes, but also neurological conditions such as Parkinson's disease. And I used to get a lot of questions about those on the Pharma Advice Service. But also they've moved more into the special needs. So Matthew Lim, who's a specialist in
Yes.
special needs, has written this section. It's so good
Okay,
and
great.
so instructive, especially say for people with cerebral palsy, but also elderly patients with dementia, as well as neurodegenerative illnesses like motor neuron disease, or as I said, Parkinson's. So some really great constructive advice. So that's another section that you just have to keep an evening free and read it. It's so good.
Oh, no, that's really helpful. Thank you. I remember we spoke with Andrew Lee, sorry, a special needs dentist, and I've spoken to Trudy Lim, as you know, about special needs dentistry and really the fact that, and I think the stat, forgive me, I might be slightly off, but there are that many patients with what would be classified as a special need in Australia that if they were
Mm.
only seen by special needs dentists, each of them would have a list of over 80,000 people. And in order just to do a checkup on each of those patients, on their list would take 5 years
Oh my
without any
goodness.
treatment. Now, when you I might be slightly off with the numbers,
But we
you
get
would
the
have to
message.
listen to the original podcast. But I guess my point is that when you put it in those terms, there is a real need. These patients are going to walk into your surgery, and you, my friend, are going to need to know how to treat them. We can't just refer everything. We are
Mm,
general dental practitioners, and it's within our scope. And
totally.
yeah, so it's
Yeah.
really good that's there to
And I
help
think
us.
especially for patients you might have seen for a long time throughout their life, and these issues that make them special needs, but in their later years, this is a patient you've cared for, you've managed their oral health for all this time, and now they've got Parkinson's or now they've got dementia.
Yeah.
It's better if they stay with you. And there's only a handful of things you have to learn and new skills to acquire. So, dentists are smart. I think everyone can do it.
That's brilliant. Thank you, Jerry. Really appreciate your time.
No
That's been
problem.
super helpful. And thank you all for listening. I really hope that this podcast has been helpful, and we look forward to sharing more guidance with you in the future. If you like dental protection podcasts and you'd like to hear more, please subscribe and leave a review.